Hi, my name is Katie Agarwal. I'm a geriatrician. I work at Baylor College of Medicine in the section of geriatrics in the Department of Medicine. I am pleased to join you today to speak to you about the problem of delirium in older adults. This content is brought to you by the Southeast Texas Geriatric Workforce Enhancement Program, which is a collaboration between Baylor College of Medicine, the Michael DeBakey VA Medical Center, and several other universities and community programs within the Houston area. The Geriatric Workforce Enhancement Program is a network of 48 other GWEP programs across the United States that are all under the auspices of the Department of Human Resources and Services Administration in Health and Human Services. Again, this program is the first part of two on delirium in older adults. This first initial part will be focused on facts around delirium and the recognition of delirium. It's also very important to note that we will have a delirium toolkit available to you with many resources that will be helpful. So the objectives of this program are to describe critical features of delirium, differentiate delirium from dementia, discuss the negative impacts of delirium on older adults, and to help you be familiar with assessment tools to recognize and diagnose delirium. One important issue to discuss with you is something called the 4Ms. As we all aim to be age-friendly health systems, the 4Ms are a framework to help us consider how we care for older adults. And in the inpatient setting, in the hospital setting, delirium is the key issue that we're all trying to prevent and manage better to improve outcomes for older adults. So the 4Ms include what matters most, what is most important to the patient, and aligning the care plan with those focal points. Medications, reducing inappropriate medications that may cause delirium and helping to educate patients and caregivers about the medications. Mentation, looking for causes of delirium with any changes in cognition or behavior, and screening for delirium on a regular basis. Another important part of mentation is trying to help support sleep without medications and ensuring that patients can communicate well with glasses and hearing aids. And lastly, mobility, but definitely not least. Early, safe, and frequent mobility is very important in helping to prevent delirium as well as to improving functional outcomes for older adults in the hospital. So what is delirium? Delirium has many names. You may see it as altered mental status, toxic or metabolic encephalopathy, or an acute confusional state. But they all are really synonyms for this problem, which is a disorder of attention and awareness. It develops acutely and it tends to fluctuate. It really is a problem related to some type of medical problem. Some type of illness is typically the underlying cause of delirium or perhaps a medication, and so we need to seek the causes. Delirium is very prevalent in older adults that are in the hospital. It's very common when a patient comes to the hospital from the emergency department or perhaps after a surgery, or also especially common in the intensive care unit, especially when a patient is on mechanical ventilation. It's of course also very common in hospice at the end of life. And we may also see it some in the community when patients become ill, and of course in long-term and post-acute care settings. Delirium you might think of as an acute brain failure with an acute change in mental status, inattention, and a fluctuating course. It's often the first sign of a medical emergency, especially sepsis in frail older adults. It is under-recognized typically, and we must always be on the lookout for it. Delirium is very dangerous. It increases the risk of death both during a hospitalization and in the following months after the hospitalization. It's related to increased frequency of developing dementia, increased institutionalization after a hospital stay, high risk of functional decline, and high risk of readmissions. Several papers have documented the long-term effects of delirium, which were previously unrecognized many years ago. Especially more recently, Wes Ely and his group documented in the New England Journal of Medicine a large study looking at the outcomes of patients with delirium who were seriously ill in the intensive care unit with respiratory failure or shock. The longer the duration of delirium was consistent with the worse global cognition at 3 and 12 months after recovery. It was very common to have long-term cognitive impairment after delirium and critical illness in patients of all ages. And 40% at 3 months had scores, cognitive testing scores that were 1.5 standard deviations below the mean. So what does delirium look like? There are different motor forms of delirium that we see. The most common is hypoactive delirium. Most older adults, greater than 50% of cases, present with the sleepy type of delirium. They're less interactive, they appear apathetic and sleepy, especially with sleeping more in the daytime. About 25% may present with a hyperactive delirium, who are more agitated, very needing to constantly move around, and of course are more difficult to manage in an inpatient setting. And then of course some patients may have a mixed form where at times they'll be hypoactive and very sleepy and then quickly change to hyperactive and more appearance of agitation. The hypoactive form that most older adults present with is problematic because we may miss it. It's not very common that we're concerned about a patient being too sleepy or too quiet, but this is something that we all need to be aware of. So delirium comes from the sum of predisposing and precipitating factors. The greater the burden of predisposing factors, the fewer precipitating factors are required to cause delirium. This explains why delirium often occurs in frail older adults who have many underlying risk factors for delirium. Some of the risk factors include older age. Having an underlying dementia or cognitive impairment is the greatest risk factor for developing delirium when a patient is ill. A history of prior delirium with previous illnesses, depression, functional impairment, history of falls, malnutrition. Sensory impairment is another important factor to recognize, and thus we should always try to help patients with hearing amplifiers and glasses whenever possible in the inpatient setting. And of course, the severity of illness is also a major predisposing factor. Some of the precipitating factors that occur in the hospital setting are medications that we give patients, especially sedative hypnotics, also illness with fever, sepsis, dehydration, treatment with multiple medications. Another may be the withdrawal of medications. If a patient is used to taking benzodiazepines or alcohol at home and then having withdrawal from that. Bladder catheters are associated with increased frequency of delirium. Hypoxia or hypercarbia are important to remember. And of course, infection and sepsis. So it's very important to recognize that dementia increases your risk for delirium, and delirium actually in the long run increases your risk for dementia. But delirium is not the same thing as dementia. These are different problems. Delirium has a more acute and fluctuating course. It's potentially reversible, related to some type of acute medical illness or medication. But dementia is chronic and persistent. It's irreversible. The primary deficit is short-term memory in dementia, whereas the primary deficit in delirium is attention. So many patients with significant levels of dementia will be able to attend and stay on task with you during testing, but patients with delirium will have impairments in their attention and thus will also have difficulties with memory because they're not attending to the task at hand. A major problem with delirium is poor recognition. It is not recognized very frequently by physicians or nurses. It really does require an assessment tool. If you're not looking for delirium, you may miss it. Orientation is not a sufficient screen to look for delirium. There are multiple tools for screening and diagnosing delirium. I'm going to list a couple here. The 4AT is the 4A's test is more suited for nursing staff. It has good sensitivity and specificity, but it's also useful for medical providers. It is very popular in the UK. The 3D CAM performs best when completed by medical providers with excellent sensitivity and specificity. The 3D CAM is short for the 3D confusion assessment method. The confusion assessment method was initially created by Sharon Inouye in the late 1990s, and they've had different versions that have developed over the years. The 4AT tool, it gives 4 points or greater is a positive screen, and one of the key factors is alertness. If a patient is not alert, is too sleepy, or is too hypervigilant or agitated, they will receive 4 points and thus become a positive screen for delirium using the 4AT. If they have a normal level of alertness, then we'll look at the orientation, do a test of attention. They ask the patient to do the months of the year backwards, and then they'll ask about acute change in cognition, in thinking, or perhaps having hallucinations. The features of the confusion assessment method include one, that there must be an acute change in mental status with a fluctuating course. So an acute change from baseline, how the patient was performing prior to this illness is the important issue, is understanding how they were thinking before they became sick. The second feature that must be present is inattention, with some type of attention testing, as was mentioned in the 4AT, for example, perhaps saying the months of the year backwards, days of the week backwards, or other tests. The third feature is disorganized thinking. This may include some of the psychotic features like hallucinations or delusions, but it does not have to include that. And then the fourth is an altered level of consciousness, so being too sleepy or too hypervigilant or too hyper alert. So for the CAM tool, require features 1 and 2 and either 3 or 4. So as I mentioned, the critical issue in delirium assessment is change from baseline. This is how the patient was performing prior to their current illness. If the patient is confused, we really should not assume that baseline if the patient is confused, we do not assume that baseline was a normal state. We don't assume that confusion is their normal state. Always assume that prior to this illness they were not confused. So you really do need to do some investigations, ask someone who knows the patient well, look for recent changes in thinking, level of interaction, and look for delirium superimposed on dementia. You'll frequently get the story, he was okay until. So it's more of an acute change. It may be that he was okay until a couple of weeks ago, but he was okay until this time. That's the frequent story we get with delirium. Testing attention is a critical issue in delirium assessment. Inattention is always present in delirium, but not in dementia. Patients that look normal are often inattentive when we test them. As I mentioned, you may try having your patient state the months of the year backwards or the days of the week backwards. Digit span is also a popular test of attention, asking the patient to repeat 5 random numbers forward that you give them and 3 backwards. Another one is the letter A test, which is used in the intensive care unit. In the intensive care unit, if the patient is not speaking or perhaps they have a new tracheostomy, you might ask the patient to tap or to squeeze your hand only when you state the letter A, and you would give 10 letters and have them squeeze only on the letter A. Disorganized thinking is another factor in delirium, and I like the question, have you seen or heard anything that seems scary or unusual today? And then moving more into the questions around hallucinations. I think that it's very difficult to initially come out with a question around hallucinations, and I find that this is a nice introductory question, and then asking some more about things that they might see or hear if they describe these issues to you. Patients with delirium or dementia typically have visual hallucinations instead of auditory. Any new occurrence of hallucinations or change in behavior should prompt an evaluation for delirium. As I mentioned before, you may see a change in level of consciousness or alertness in patients, and really anything other than a calm, normal level of alertness should be considered abnormal. So take-home points: delirium is dangerous and may be the first sign of serious illness in older adults. They will need further evaluation. Delirium is under-recognized, so you really should use a formal assessment tool to evaluate for presence of delirium, and we have links to those assessment tools in our delirium toolkit. Older patients with delirium most frequently present with a hypoactive or sleepy version of delirium. Patients with any underlying cognitive impairment are at the greatest risk for delirium. And patients with delirium will have difficulty completing attention tasks, but most patients with dementia should be able to complete test of attention. So then the next steps are to look for and treat underlying illnesses. Here are some resources that we'll also have listed for you in our delirium toolkit. We understand that your time is extremely valuable, and thank you for your commitment to providing age-friendly care to older adults. So in the next course, we'll cover these aspects of delirium: the evaluation, management, and prevention of delirium. Because once you've diagnosed delirium or you have a high suspicion for it, you must evaluate for medical illnesses and causes, and then of course manage it. Thank you for joining us.